So as soon as you hear the recording, you can wait 5 seconds and start. Okay?
Okay. Welcome and thank you everyone for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on December 3rd, 2020. And I'll poll each member. Oh, thank you. I'll poll each member for their vote. Jose Pagan?
Yes.
Dr. Katz?
Yes.
Sally Hernandez Pinero?
Yes.
Fenioski on?
He's not on as of yet.
Okay. Ms. Lowe, Barbara Lowe?
Yes.
And I vote yes, so the minutes are adopted. And next, we're going to move on to a financial update from the Chief Financial Officer, John Alberg, and I think he's joined by several members, James Cassidy, Salima Tyler, Micheline Farag, Krista Olson, and Matt Spiegler. There's a lot of good information to go through here, so I'm going to ask that members hold their questions to the end, and I'll poll each member to ask for comments and questions after John and the team get through. Is that okay with you, John?
Yes.
Absolutely.
Okay. Great.
Can you hear me fine?
Yes, I can hear you.
Yes. Well, first I want to say thank you, for your time, and it's wonderful to, see everybody again. This is our report, through the second quarter, our performance through the second quarter. And I would say in a word, right, we've I think gone past our 1-year anniversary date of COVID. In a word, I would say the health and hospitals finances are stable, right? There's a lot of volatility within our plan, and James will go through at the very end the changes in the financial plan since the last update, and you'll see that volatility. But overall, we're performing very well. When I'm asked how to explain, and I've talked to some of my counterparts in other hospital systems, how are you doing? I think everybody pretty much has the same sort of view, right? And I think it's best to maybe break that view down into the externalities, the forces that are affecting us from outside the organization. And then also, look in terms of how are we doing internally, and that's really our strategic plan. But, externally, we talked about it at our last, meeting that there was excellent news that back in January that, the DISH cuts were delayed for another 3 years. Obviously, before COVID, that was one of the most significant elements to our plan. So that's phenomenal news for us for the next 3 years that those cuts are delayed. With the help of, President Biden and Senator Schumer, the FEMA cost sharing was set at 100%. And that was also, very good news for us. I think the other outside forces, and James and Linda will go through this, but you heard us talk about the DISH glitch, right? That was a very significant, there was an error made in the calculation of the FMAP, all very technical, and it affected just health and hospitals, and that impact could have been as great as $388 million if it played out for the whole period. Our analysis indicated that could almost be $1 billion hit to health and hospitals. That was fixed in the American Rescue Plan, so we're grateful for that. The American Rescue Plan also had fairly significant amounts of relief for both the city and the state, and we hope that will translate into better budget outcomes. The state is in the negotiating phase of their budget, which is due April 1st. We looked at both House bills, one House bills were released over the weekend. We're analyzing those now. They look to be more favorable. And then, the last thing that we've, been working on is really our response to FEMA. We've actually, we'll estimate spending over $2 billion on FEMA. We've received $1.2 billion in relief. Thus far, we've reached this inflection point. So we do need assistance from FEMA, and we did respond to them last week or the week before, to some questions. So that certainly is next up for us. So those are the external issues. Internally, we're doing fine. I think, is this the first slide? Yeah. I'll just direct us to the first slide. So internally, we're, yep, that's it, thank you. Through February, our cash balance was $400 million, which is basically where we wanted to be. We're reporting a positive budget variance. We're beating the budget by $115 million, or 2%. I think it's also worth pointing out that if we weren't covering the COVID cost and we were receiving the FEMA funds, that margin would be somewhere in the neighborhood of 245 million. So even do better once the FEMA dollars start to flow. I think quite remarkable is that, our direct patient care receipts, $398 million when you compare that to the actuals from the previous quarter last year. That's really quite remarkable. And last year, our results were almost $500 million or over $500 million. So patient care receipts doing very well. Volumes are down despite all this, which adds to the complexity of the plan. But we'll go through that. The strategic financial initiatives, right? Despite all the distractions that COVID can bring, we still stay on pace with our strategic initiatives. And Krista will give you an update there. So I think despite it all, right, we're sticking to our game plan. Our game plan works, right? We'll deal with those external pressures as they come. We'll deal with them one at a time, and we'll keep our focus on the things that we have to do, right, to strengthen health and hospitals for the future. So that's basically my summary. We'll keep going here. I think next slide. James, you want to do this one?
James, can you please unmute yourself?
Sorry about that. Can you hear me now?
Mm-hmm.
Yes.
Okay. So as John mentioned, we closed February with approximately $400 million cash, which is about 18 days from our last meeting. That's where we expected to, right around where we expected to end the month, which was good. As John mentioned, it's important to be stable during these uncertain times. The big thing that we're looking at between now and the end of March is our next dish payment that we've worked around the state for about $511 million. That is a really important payment for us. You'll see it would allow us to have $650 million at the end of the month, or nearly 30 days. We're hoping to, get that in the door. There's been lots of conversations. We do have other strategies that we'll employ, but we expect that we will get those funds. Nonetheless, even if we close March in that strong position of almost 30 days cash, we will still face challenges between now and the end of the fiscal year, given our spending on COVID and other costs. We definitely need to make sure that we're getting additional revenues coming in. The big thing that John mentioned is really working with FEMA on the subsequent reimbursement package we have with them now. We expect that based on that package, we should receive $330 million from it, and we've asked that be received in April. In addition to this, we are hoping that with the positive news of the 100% cost share, our first payment package that we received of about $200 million, which is at a 75% cost share, will go up to 100% and generate close to $70 million more for us. So we have those things in play and in progress, and with that, it will certainly help us maintain our stability for the next couple of months. Got anything to add there?
No, that's good. Thanks. Salima or Micheline?
Salima, go ahead. Let's go through this one.
Hi. Yes. So this is just a summary of our cash receipts, and it shows, this is an illustration of what John spoke about earlier, where although our outpatient and ED and inpatient volume is down, our total cash variance quarter to quarter, year over year is up. It's up for a number of reasons, which are ticked out in the chart to the right. So you can see that we've had CMI increases, which are resulting in higher reimbursements, continued revenue cycle and managed care contracting enhancements, which are driving up our cash. We do have some unbudgeted testing revenue that's also helping us out on the outpatient side. And we have risk payments that are not included here because of timing. So the risk is not factored into this variance here.
James, you want to do this one?
Sure, I can handle this one, John. So looking at the external risks that John had sort of mentioned earlier on, we have had some success thus far, indicated by the check mark. So as I mentioned on the previous slide, we have now received FEMA reimbursement at 100% federal. The important part is now making sure we get the cash in, but obviously that was a major plus that President Biden instituted in his first week or so in office. The second thing, as John mentioned, the federal dish cut, the 3-year delay that was passed back in January. That was enormous, about $600 million a year to our plan for the next 3 years that otherwise would have been cut. The third item here, the federal dish EF map glitch, which was rather technical. We still have it as a work in progress here, even though it was in the bill signed by President Biden. What we're waiting on now is the official guidance and the funds essentially to be added to the federal allotment that would allow us to draw it. So that's both a federal and a state action that we expect to come quickly. And so that should be checked off, very, very soon. Finally, our last two items, which certainly are things that we're in progress on. We have several initiatives we're working on jointly with the state, the city. In terms of Medicaid, we're working on finalizing some of our agreements and working on some rate packages that will allow additional funds to flow. I can go through some of this later on when I go through the financial plan, but this would essentially help us to achieve the supplemental Medicaid portion of our strategic initiatives that are now included in our financial plan as the most recent update. And then finally, also associated with the financial plan, we do have state and city budget risks that have come thus far. In terms of the city budget, their preliminary plan did have us one-time repaying debt service that had previously been a forgiven payment. So that's $212 million of a hit to our plan. We also have the governor's budget, which John mentioned. That came out back in February, and the One Houses came out. The governor's budget would impact us by nearly $500 million over 2 years. The biggest impacts would be the public indigent care pool being eliminated, which would be close to $120 million a year for us. There's an additional 1% across the board cut that's in addition to the 1.5% across the board cut that was implemented last year. And there was a COVID clawback, as we call it, a reduction in managed care rates related to COVID underutilization that will hit our risk pool. So all those pieces together, there are definitely things we're still working on. As we've seen the federal bill pass, as we see the One House budget that we're continuing to manage, but certainly things to keep on the radar.
James, this is Feniaski. I just have a question. In the fiscal year 21 for the city, you mentioned the 212 million debt service cut. Does that mean that the city before didn't charge health and hospital for the debt service, and now in the budget is charging? Can you explain that a little bit?
Sure. So the city had previously been responsible for paying for the debt service on our city debt until fiscal year 16, and the city began forgiving it on an annual basis. So they were having the cost on our behalf. For this year, it's a one-time reimbursement. They're again asking us to pay as of their preliminary budget.
Okay, thank you.
Penny, you joined a little late. We're going to try to hold the questions to the end because they've got lots of presenters. But
Sorry about that.
Okay. Go ahead, James.
I think that was all on that slide.
Hi, good morning. This is Micheline. So on this slide, we're doing a deeper dive into our financials, showing our performance through December. So two things are seen here, what John had spoken about with our net positive budget variance on the two sets of bars on the left, with the purple one representing receipts, green representing our disbursements performance against budget. So here you see the two of them give you a positive variance of 115 million, with the receipts exceeding budget by 252 million. Subcomponents of that you see in there, 204 million of that is in the patient care revenue, where you see the impact of the higher dollar amounts coming in for the COVID patients, the Medicare rates, and also some of the catch-up risk payments. On the disbursement side, we are higher than budget with 38 million in non-COVID OTPS spend, or I should say, in this case, better than budget with 39 million, with our OTPS spend really more focused on the COVID piece of it and lower in association with the volume outside of COVID. Another thing you see on this chart is the reference both James and John made in terms of the criticality of the timing of when we receive the cash for our FEMA payments. So right now, as of that December data, we have about 129 million in COVID expenses or disbursements that have not been offset from a cash perspective that we hope to receive within the fiscal year. On the right side, the two sets of bars here represent the cash for the patient care receipts and disbursements against our performance for the same period last fiscal year. And this is where Salima went into a little bit. This is where you see the 21% better from year to year. You see our patient care is 480 million better, with our the leading contributor to this is our revenue cycle managed care initiatives and other revenue maximization initiatives that we have done year to year, contributing to this piece of it. And we also have the case mix index as well is up year to year about 22%. For the disbursements overall, we are about 69 million higher, mainly due to COVID spend, again, that we referred to earlier, that has not been offset from a cash perspective.
Micheline, just two things I wanted to clarify on. On the right-hand side, the disbursements exceeded budget by 39 million. I think is that the 136? Should we correct that for the?
So on the left side, the green is 39 million against budget. So that is better than budget. So better than budget would be lower than budget, not exceeding. So the top of the graph shows better than. So
Right.
on the revenue, it will be higher than budget. On the expense, it will be lower than budget.
Right.
And the bottom part is worse than budget. So it'll be.
I see. So you're just referring to the OTPS is better, not the total disbursements. The
Right,
total net
exactly.
disbursements are worse at 136. Got it.
Exactly. As a result of the timing of the COVID, the FEMA receipts to offset our COVID spend.
Right. And then another point was the patient care receipts. Does that include risk pool or?
Yes.
Okay. So I just want to make sure it does, because that's why there's a difference between what we
It's
thought.
part of it.
Right.
Yep, exactly.
Okay.
Okay. All right. So on the next slide here, we're looking a little bit at our staffing and the investments that we have made this fiscal year through December, as well as since the start of fiscal year 19, which is the second set of numbers at the bottom. So as you see, since fiscal 19, we've made large investments in nursing and nursing support, with nurses up 624, as well as our nursing support up 253. We've also made investments in revenue cycle and our business plans, which have expansions and revenue offsets coming in, as well as, of course, our revenue cycle efforts. When we jump to this current view, we see we are 122 staff up since the start of the year, and that is distributed across our nursing titles, our physicians in residence. We also have some social workers in the last bar of 62 contributing to that. And for clericals, really, that is a provisional client navigators for point of entries that have been hired across some facilities. Again, significant investments happening on nursing, on the revenue cycle side, and now we are really focusing on the strategic plans as we come out of this and go into our new fiscal year, focusing on our OR growth and our efficiencies, our primary care enhancements, and some of the strategy that will be talked about later in the slide deck. This one is another deeper dive into the revenue. So it's a different view. We did look at, for example, earlier, our patient care revenue is 480 million higher than FY20 actuals. Here, what you're looking at the bar graph is the pure dollars as opposed to the variances, which we looked at earlier. But these are the dollars that basically speak to our performance by inpatient, outpatient, and risk, as Frida asked earlier. You see here the components of each that contribute to that patient care receipts, totaling to the 480 million higher year to year. We have, again, patient care improvements attributed to our acuity for our COVID patients, but also our strategic initiatives is really where you see that year-to-year improvement that have contributed to this higher patient care dollars. Our CMI also is up, as mentioned earlier, by 22% year to year. And we maintain a portion of that. Thank you.
Hi, good morning. I'm just going to go through our strategic initiative update here. At a very high level, we are doing well compared to our risk-adjusted targets, which are the amounts aligned with our financial plan for this fiscal year. We also monitor internally to higher targets and are tracking well there as well. Compared to last quarter, the line of sight has increased substantially, with the increase being primarily in the rev cycle and managed care category. Specific improvements can be found in the AR recovery, the one-time managed care settlements, enrolling the uninsured, and capturing high-cost outliers. Assessing whether these amounts are recurring and what additional opportunities there may be next year, while also being mindful of timing and continued COVID-related risks are what we're focused on now. I won't read through all of these in the interest of time, but I would note that we are measuring an array of metrics associated with the various initiatives and include both higher and lower performing items here. I think the managed care metrics are particularly impressive, including both the settlements and ongoing negotiations. Also notable are the continued system efficiencies by our enterprise IT services and the continued work on the conversion of HARP eligible patients and SNP eligible individuals into those programs. There's a slide in the appendix that goes into detail on those VBP efforts if you're interested.
Matt, did you want to go through these, or would you prefer that I?
Go ahead, John.
Okay. Yeah, so, despite it all, we are looking forward and starting our planning for, next year's budget. And these are kind of the major themes that we've laid out that, similar to last year, we developed, major themes that we think are consistent with, the clinical direction of health and hospitals. So we've listed them here. You've heard us talk about, value-based payment. We certainly want to build on those efforts. As we all know, that between Health First and Metro Plus, that's a sizable portion of our revenue stream. So we're taking steps here to better manage our risk pools. Retaining and maximizing attributed, membership. I mean, what we've seen through COVID is a very substantial increase in membership growth with health and hospitals and Metro Plus. There's a chart in the back. We did, just as a matter of expediency, we put some, which I think are some very nice charts in the back that show the membership growth, but retaining that growth and retaining that revenue is obviously very critical. Growing primary care panels, is another effort, working with ambulatory care to assign patients to primary care physicians so that there is that attachment and that we can manage the program from that perspective. Doubling down on access and efficiency gains. Many of our healthcare plan partners are now focusing a lot on access to care and quality of care, and then within value-based payment, the efficiency by which we render care. We've done tremendous amount of work in peri-op, working on referrals, working on patient flow through The operating rooms, that work will all continue. We'll grow upon it. Telemedicine's been a success. Virtual express care, right? Finding different ways to, tailor our treatment models to best, suit our patients' needs is very critical. And telemedicine will be something that we look at expanding on. We presented last time on reducing denials. Obviously, that's a big effort for us and Margie's team. My chart. I think one of the things we've learned through COVID, and there are some good things within COVID, is the digital connection that we must have with our patient. It allows us to stay connected, provide better care, have them access the service system more efficiently, and be in charge of their care. So you'll hear a lot from us going forward about my chart, and then COVID readiness and flexibility. So those are the themes. We'll keep you apprised as we move through the budget development, process. It's really kicked off now. Federal relief, I'll turn it over to Linda. Linda.
Linda, can you please unmute yourself?
Sorry about that. So we wanted to provide you with an overview of the American Rescue Plan Act, which was signed into law last Thursday. We've already touched on a couple of the most important financial pieces for health and hospitals, the first of which was the fix to what we've been calling the dish glitch, which essentially corrects a direct error in earlier COVID relief legislation that introduced a cut to Medicaid dish funds that, if not corrected, could have resulted in a reduction of payments to health and hospitals of almost $900 million over 3 years. So that was a main priority for this. Very happy to see it included. The second piece is inclusion of relief funds for local governments. This, importantly, is funding that can be used by those governments to close gaps and replace lost revenue that had trickle down to reductions that are harmful to healthcare providers and other services across the state. So it doesn't fully close the problem, but it's very important, significant funding that will be helpful in the negotiation with the upcoming state budget. Beyond that, there is funding for implementing the vaccination plan, continuing to support test and tracing, that may also provide support to both state and local governments, a portion of which we expect will provide some funding to New York City for the support of the T2 program. So it's not directly come to us, but important to the work that we're doing on behalf of the city. Beyond that, there's not a lot of direct funding for providers that we expect to come to us, but there is some new funds. We'll have to wait and see how they flow through. Of this nursing home funding, total $700 million, it seems that at most $200 million may be distributed directly to nursing home facilities. So we will be on the lookout for how that funding becomes available. There are a number of other initiatives that we'll have to wait for much more detail to see how they flow through, but that includes for workforce, for behavioral health initiatives, for community health centers. There was a significant amount of money put in specifically for rural hospitals, but nothing new for other general hospitals. There was also important expansion of access to health insurance and subsidies for health insurance that were important policy changes included in the legislation. So overall, it was a very strong package, and we think advanced a number of our goals.
Hi, you see here the test and trace fiscal year 20 and 21 budget updated. This budget includes funding for all of the different pillars of testing, tracing, the Take Care Isolation Program, as well as public awareness. It includes funding from the ELC for DOHMH's work, and it now also includes vaccine. This amount has increased to $2.1 billion due to program expansions reflective of local policy changes, a prolonged second surge, and again, the inclusion of vaccine. Just a few details on what's included. Testing includes the pop-up brick and mortar testing sites, as well as An enhanced focus on mobile unit testing included rapid testing, PCR, and school testing, all at no cost to the patient, but we do bill insurance for most of those locations. The tracing program includes all contact tracers, including case investigators and monitors, as well as supporting some of the DOE work and the traveler work. We also have free isolation hotels for cases and close contacts. We provide resources to those who are quarantining at home as well. And most recently, we've joined the citywide vaccination effort and are running 3 of the vaccine distribution sites 24/7, as well as providing support for the canvassing work and outreach work to try to bring people to these and other city-run sites. We expect to receive a significant allocation of ELC funding from the December COVID-19 relief bill. And as Linda mentioned, we also, in the city also expects to receive additional funding from the American Rescue Plan. FEMA will, as John mentioned, reimburse eligible T2 costs at 100%. This is also, we assume that FEMA will cover any testing site expenses not covered by billing revenue or ELC. And the city, through our MOU, covers anything that is not federally funded, although again, looking to find as much support there as possible. And they, just a note, they continue to advance the funds for us to cover our expenses, and we received $100 million last week in that support. Thank you.
And again, here, I think I won't go through these slides. We decided, to try to move things along, but I would, there's a lot of great information here. And we will always obviously be available to answer any questions after you go through those slides. I think, James, do we have one other piece of business, Frida, that need to cover?
I think you want to go through that first, or should we have, we can ask the members for their questions on the first part. Is that?
Sure. Yeah, that makes sense. Yes.
All right. So why don't I start with, thank you everyone for your great presentation. And I do think if the board members have time, the flipping through the slides in the appendix would be great. But Jose, do you have any comments or questions?
I don't have any questions. I just want to commend the finance team for all the work they do in terms of keeping an eye on opportunities that are coming our way and making sure that the resources are used in a way that thank you so much.
Thank you, Jose. Dr. Katz?
No comments. I agree with Jose. We have a great finance team. Thank you.
Sally?
I have several questions, if you can bear with me. The 877 nurses that we've hired since 2019, does that include the ramp up during COVID? Are those is that a stable number now for H&H?
Yeah. Yes, I think on that slide, we're giving you really 2 views. One is the growth that's happened since the beginning of the year, but I think even more importantly is looking at the growth going back to FY19, because that really shows our overall strategic plan in terms of how we want to build the workforce, right? And there's really 2 major elements to it. There's the nursing and the clinical support and the physicians. That's the clinical side of things. And then down the line is the business opportunities. But with respect to nurses, I think when you add the 2 together, it's almost 900 between nurse and nurse support, right? We're very proud of that. And one of the things that we've done, and we could come back and provide more information here, but we have on the inpatient side built out the nurse staffing model. And that's really what was driving this growth, is to accommodate that model. And we've actually reached a point where we're very comfortable with it, and we're kind of now operationalizing out the model, working with the chief nursing officers and the CFOs to really keep an eye on the relationship of nurses to beds, which in this environment, it's difficult, right, because of the volatility. But we do have the model, and we have made the investment that Dr. Katz had asked us to do. Yeah.
Great progress, great progress. On the American Rescue Act, on the areas where there's broad language, like, funding for mental health, strengthening mental health and substance abuse services, something like that. How long will it be before we know how, how that rolls down to us specifically?
Linda, do you have any insight on this? This bill's still pretty fresh, but.
Yeah, it sounds
Yeah.
like it.
Yeah, I don't think we know yet. I think, we expect that the administration will typically, hopefully within a month or so. I think probably not as quickly as things moved after the initial bill, but some of this comes through in the form of sort of add-ons to existing grants, and that may be a way that they move to get some of the clear.
Sorry, Linda, I think in the boardroom, maybe there's somebody near the microphone that's ruffling papers.
That's me, sorry.
Sorry. So Linda, I'm not sure if everyone could hear you. You were cutting in and out a little bit for me. Do you mind? Or Sally, were you able to?
Linda, if you turn off your camera, your internet should be okay.
Internet is
Can you hear me?
Wasn't me.
Yes.
So I was really just saying that we don't know, but that we hope that they will, take action quickly. We expect that they will try to do that, and that one option that they've used in the past was to add some of these funds to existing grants as, sort of supplemental awards, and that enabled them to move quickly. So we'll have to watch and to do that again.
Just have one other question. Now that Alicia showed me how to turn it off.
You hit the button there. There.
Thanks.
Okay.
Okay, thank you. And looking at the FY22 January financial plan in the appendices, I had a couple of questions. One, whether the projected 20.
Yeah, we were gonna cover that, Sally, when we got done with all the questions.
Oh, I'm
if you wouldn't
sorry.
mind.
No.
Yeah,
Okay.
we thought it might be better to kind of go through all the questions because I think it'll maybe help us understand.
Okay,
this chart.
thank you. I'll wait.
Okay. Sally, are you okay? We can move.
Yes, I'm good.
Okay, great. Fenioski?
Thank you, Frida. I just have a question. If you go back to the budget for test and trace and the vaccine in particularly, are we expecting that number to increase? It seems to be low, but maybe only accounts for the 3 24/7 vaccination sites and doesn't account for the vaccine that are administered through the regular offices in the hospitals. So I just want to understand that budget.
That's correct. This is only for the 3 sites that are being managed by T2 at Brooklyn Army Terminal, Bathgate, and City Field. We do have additional vaccine sites throughout our system at both Gotham and the acute hospitals that are not being included as part of the trace budget because we're using those really to focus on our patients and staff, and they're not part of test and trace. And then the city is also running quite a few other vaccine sites through DOHMH and other entities that are also not included here. So this 73 million is only those 3 sites. So it's much smaller than.
Yeah, that's what I was a little bit surprised with the smaller number compared to all the others. But I don't know, Frida, you may have to decide that. But I think it will be good to really see if there is a way to present the total budget for these type of activities, particularly the vaccine, even though they may be in different offices for health and hospital. I think that at least will be helpful for me to understand the magnitude through the system of our participation in that effort. So that's my only question.
Frida, if I can sneak in a little question.
Sure.
Test
Go
and
ahead.
trace. On test and trace, there was 179 million for public awareness, which is an amazing number. I just thought, does the city expect to get the funds it's expended thus far reimbursed by FEMA, or is that something they're going to have to absorb?
Public awareness and communications is FEMA eligible. They have to look at, obviously all of the different activities to make sure
Okay.
each one is FEMA eligible. But the intention is to claim it for FEMA, and the city would, we'll be looking at all of that, but they're reimbursing us through FEMA at the moment. A lot of those funds are, again, this is a citywide test and trace program that's managed. So this is inclusive of a lot of activities that are also managed by DOHMH as part of the public awareness.
I see.
So it's not just being directly paid for by H&H, it's inclusive of other city agency spends as well.
Okay, thank you.
I just want to circle back to Fenioski's comment. I think, Feni, you're asking to see the T2, I'm sorry, the vaccine costs that H&H has that's away from the MOU with the city. Is that what I'm understanding?
I think what I wanted to understand is that this is going to be, it is already a major effort. And I think right now, at least from the data that was presented today, there is no clear indication of how much that is. And I believe that it doesn't matter if we are doing it through our own sites in the acute care or Gotham, or we're doing it to test and trace. The funding of how that will be supported may have some similarity and commonalities, so that it will be good to look, even though it's done through different organizational units, since we are looking at the whole system, to see what that effort entails. That's my question, because right now here, it looks like we are only spending 73 million in vaccine, when we all know that there is a lot of money spent in the acute care hospital and the Gotham. And I don't know if you know how much that number is. It would be good to have it all together. That's my suggestion.
We can
Kristen.
certainly come back. Yeah,
Go ahead.
I don't have that number off the top of my
Oh,
head.
it's far below.
We are tracking it separately, and we'll be claiming that the net difference between what we bill and what we incur to FEMA as well. But as Frida mentioned, this is the part that's covered by the MOU, and we track that separately. But we also can provide the number for the H&H vaccine sites.
Yeah, I think that I understand that there may be different mechanisms on how this will all be funded, but I think the same way that we're looking at our investment or our participation in different phases of the pandemic, it would be good to understand holistically the vaccine.
Sure. Okay.
Thank you, Feni. And any other questions?
It's Barbara Lowe. Can you hear me?
Oh, yes, Barbara, please, go ahead.
I have to say I'm very impressed with this report. It's very clear that our investments have paid off, and the performance of people at the line level, putting in place the kind of controls that were specified as best practices, seeing the nursing productivity element taken into consideration is really wonderful. I only want to make some comments about two vulnerable populations. It's the young people and the little people in schools, the staffing model for that, and of course nursing homes. We are faced with a horrible report from the New York Times. I don't think we have that problem, and really it's because the kind of input in clinical eyes on the nursing home patients were somewhat undermined. I think we need to only call nursing homes skilled nurse facilities. I am very aware many of us have had family experiences where we don't see but one nurse and other unlicensed staff. And I think that lends itself to the kind of model that had the worst performance with COVID. But thank you so much. I'm done.
Great. John, did you want to say something? I'm sorry.
Well, yeah, I was, certainly, those are two very important populations. As I recall, I think with respect to the skilled nursing facilities, I don't know the exact numbers, but we can get those. But I know that Maureen's team has done an excellent job in terms of the vaccination rate, within the skilled nursing facilities for both staff.
It's in the 90 percentile.
Yeah. It's very, very, very nice to see that. And, obviously our skilled nursing facilities, just overall quality are exceptional, right? Compared to others in the state. With respect to, kids and vaccinations, do you have anything there, Krista, in terms of plans?
Yeah, was that the question about vaccines and children?
This is Matt. I think the question was about our broader staffing model in pediatrics. I'm happy to touch on that a little bit, and Ms. Lowe, we can follow up with more detail if you'd like. Certainly, we have good access in our pediatric practices overall. I just highlight two areas generally that we are focusing. The first is adolescent and pediatric psychiatry. Major demands on our system and across the city for that, and so we are looking to scale that up and meet the demand. We've got some unique units already across our system and incredible clinicians who lead our work there. So there's certainly a great need, and we are focusing in on that extensively. The second thing internally I'll mention is, Dr. Mary McCord and Dr. Jen Havens, two of our leaders in this space, have been working on a multi-generational pediatrics care model called the IMPACT model, which provides wraparound care for both high-risk mothers and their children. It's been a very effective model for them, and we are looking at sustainable funding sources to try to scale it. And then finally, I think just the incredible success that Dr. Long and the entire T2 team have had in scaling up testing and tracing and other precautions in the school system has really made New York City an incredible leader across the nation in getting children at scale back to in-person education, which we know is so important for their overall health and well-being. So those are three things just to call out, and happy to discuss it more, because I think the children have got to be a key focus in our COVID recovery, and certainly are around the city and with health and hospitals.
Those sound like fine priorities. I know that when kids return to the classroom, I suspect there will be a firestorm from the teachers union and others, but we do have public health nurses in the system, and we have clinics that are state funded mostly, and how they will be inundated, I'm sure, but also there's sustainability and doing what they need to do for children, and also helping children to learn better about prevention. So that's what I have to offer, but thank you all so much.
Thank you. So I realize we're running a little late, and I want to get to the financial plan, but I just also want to say to the team what an amazing job you guys continue to do under difficult circumstances. The state and city budgets under a lot of strain. Very proactive, and on top of making sure you get all maximize all resources possible. So again, but actually more importantly, as we've seen from the report, and we didn't get to dive in as deeply on it, but a lot of still managing on executing the strategic plan and taking advantage of the opportunities that we've learned and the things that have happened through COVID that help us to accelerate on all of that. So again, I think it's terrific work, and if we have more time, I'd love to hear a little more on the value-based initiatives and what you're doing. But I think in the interest of time, why don't we jump, because I know Sally has some questions, on to the overview of the financial plan. James?
Sure. Thanks, Rita. And being cognizant of time, I'll try to run through this so that we have time for questions. So just for a little bit of overall context on the financial plan, this is the January 2022 cash plan that was released in February in coordination with the city. This was our first cash plan since the January 2021 plan, which we released back in February of 2020. Generally, we do two cash plans a year, one with the city's preliminary budget or January budget in around February, and the other with their executive budget in April or May. Last year, we did not release an executive budget because we were right in the midst of the first wave of COVID. There was too much uncertainty, and it really, wasn't an appropriate time for a financial update. So it is a little bit of a longer time than usual from between when we would have cash plans, given that it's been a full year. So there have been some major changes that I'll walk through quickly. In addition, I think a big message that John and I have seen here is that there was a lot of volatility related to COVID and just in general. So you'll see some major swings in our plan. But overall, just to give you the bottom line, to look at the closing cash balance, we do maintain strong closing cash balance in the next couple of years. And even in the out years, we are positive in sort of in a similar place to where we have been historically. So despite all the volatility, we had been able to remain stable and sort of in line with historical precedent. You can see, if you look at the bottom line, closing this year with an expected $550 million in cash. It dips a bit in fiscal 22 as of this release, and then in 23 and 24 bounces up and down, but still stays above sort of the point where we would get deeply uncomfortable. So just going quickly through the changes listed here, the first change, which obviously will help our bottom line overall, and especially will help that fiscal 22 number, is the EF match glitch, which has now been fixed. So as Linda mentioned, over 3 years, it would have been nearly $900 million. We have reflected the first 2 years worth of changes, which was nearly $800 million. The fact that that is fixed, once it is in fact implemented and we see the funds that flow, we will be able to make this adjustment in the executive plan. I hope that will be released, as I mentioned, in May. So that will certainly help our underlying conditions, both fiscal 21 and 22. While there are the other risks such as the state budget that we still need to contend with as we get through the next year. So that's just the first line. Going further down, though, there was some other additional changes. So there's the supplemental Medicaid adjustment. These numbers you can see are quite large, especially in fiscal 21. That's associated with cash timing rolls, payments that were expected in fiscal 20 that in fact are now coming in fiscal 21. And the dish cut delay, which I mentioned, is almost $600 million per year through fiscal 23. In fiscal 24, you can see the number actually goes down slightly as the dish cuts do return in fiscal 24. There were city changes, as we've talked about. There was the debt service repayment. In addition, there were changes in terms of timing. We had delayed some of our reimbursement to the city for fiscal year 20 into fiscal year 21 because of some of the delays in receiving our supplemental Medicaid payments. And the city also moved some funds into our strategic initiative, some of their non-federal share, to cover those city, state, and health and hospitals Medicaid initiatives that are now part of our strategic initiatives. So you can see that that's really the major reason for the decline in fiscal. Those are the three major reasons for the decline in fiscal 21. And then the out years, the funds actually increased slightly. On the COVID front, you will see that there is a reduction to our plan in fiscal 21 and then there are positives in 22, 23, and 24. The factor there is timing, really. So in fiscal 20, which is not shown here, we were a bit positive in terms of the funds from the CARES Act that we received. And then in fiscal 21, we are having greater expenses and paid out cash on a timing basis than revenue coming in either from FEMA or from the CARES Act. It's just really a realignment of timing. But you do see we do better as we get to the out years, as we expect the FEMA reimbursement, which we've mentioned is at 100%, to start coming in. We do have a conservative timeline here, but we want to make sure that from a cash perspective, we're not over promising FEMA funds, because it can take a while for them to flow, that we do hope to speed up that timeline. Moving quickly through the final changes, you can see there's a Metro Plus adjustment. The major thing here, the major positive in fiscal 21 is that we've moved up. We've eliminated our lag in terms of the timing of Metro Plus risk payments that are received. So there was previously about an 18-month time period in order to better track the value-based payment initiatives for you that I know you'd like to go into more detail at another point. We want to shorten the timeline so people can actually see their success in the funds more quickly. That was a one-time cash spin-up that'll be permanent, but it does mean that we're generating over $200 million of positive this year. That, however, is offset by the COVID clawback from the state that I mentioned for fiscal 21, and then we're just reducing the size of our risk pool given other state and different risks that are in play that we want to make sure that we're not overstating our risk pool at this point. Then, closing out, we have the state budget from state fiscal year 2021, which was the budget enacted last April. Those cuts we've been dealing with them since April of 2020, but as we did not release a financial plan with the executive budget as we normally would, this is the first time these cuts have the ability to be reflected. And then finally, our affiliate contracts, we're in the midst of working on those and finalizing them, but we are planning to invest a great deal in them. And so we wanted to make sure that the costs that will be associated with those contracts were reflected in this budget. And then finally, there's an other revenue expense line, which is just sort of a mix of multiple other small things on the revenue and the expense side that, there's a lot of little tweaks that happen over the course of a whole year. But you can see that they're slightly negative in the 21 and 22, and then they get positive as we get into the out years, which is also benefited by our strategic initiatives. So just to close out, as I mentioned, our cash balances are strong, and there's a second slide which shows our overall plan, which includes fiscal 25, which was not included here as there were no changes, as fiscal 25 was not part of the plan in January of 2021. But I think in the interest of time, we can take questions now.
Okay. James, I think Fenny has to drop, so I know he has a question. Fenny, are you still there?
Yes, I'm sorry that I have to drop in 2 minutes, but James, I just have a question. All the investment that were made in the different sites throughout the city for trace and testing, as well as the vaccination clinics, are those going to be 100% covered by FEMA, or how is that going to be managed?
Yeah, so given our relationship and the MOU with the city, it's our view that we are not at risk for anything T2 or T2 vaccine related. So those costs will either be covered by the federal government or the city will cover them if there is a shortfall or a gap between the two.
And
so
what about
no impact on us?
But what about the vaccine that we are doing? I know that with Gotham, we were doing some center of excellence, and they were kind of repurposed to support kind of the COVID efforts. Will the expense will be reimbursed by FEMA, or that will be part of our own budget?
So anything T2 related should be covered. I think, Krista, I might defer to you on the other piece.
I think you're speaking to the 3 centers of excellence. There were a couple different components to that. There were some capital funds that were included prior to COVID. Those 3 sites were in the works. But because we're now with the focus on COVID, some pieces of it are expected to be FEMA eligible, and so those are all of that work is moving forward, and 2 of them have opened. In terms of your kind of in an operating function, those will be they're not covered by T2. Those are our 3 sites. They'll be part of Gotham, and we'll work to identify any expenses that are COVID related and try to get reimbursement through FEMA. But much of it is just an expansion of our ambulatory care capacity.
If I can add for Fenny's question on the vaccines, the vaccine, of course, comes to us free, so we don't pay for the vaccine. If the person has insurance, we do bill the insurance for the administration fee. We charge no copays to the individual. An open question is whether or not the administration fees for uninsured patients can be claimed to FEMA. And you know what, our approach will be to be as assertive as possible on trying to get payment for as many things as possible. I think one of the reasons why John points out the risks is that FEMA pays, sometime in the future, and sometimes makes its own interpretations about what is an acceptable expense versus not an acceptable expense. And often it comes down to a negotiation. That's certainly how it worked, say, with Superstorm Sandy, where every expense that you put forward may not actually be accepted, or the total amount may not be accepted, or the timing may not be accepted. But certainly, Penny, it's our goal to try to get as much as we can via FEMA.
Thank you, Mitch, for the clarification. Just another clarification. Are we still using the consultant that have helped before for reimbursement or not?
Yes, yes.
Okay.
John Levy's his name. He's very valuable to us.
Okay, thank you. I'm sorry I have to drop off. Sorry about this. Okay, see you. Bye-bye.
Thank you, Fenioski. Bye.
I have a quick question, Frida.
Yes, go ahead, Sally.
Yes. I just going through the last page of the January financial plan. I'm not sure I'm reading it right. So, on the expenses, on other than personal services, you have a reduction of about $2 billion. Is that because there are like one-time costs included in 2021? Or are there additional OTPS cuts?
No, that's exactly right. The $2.1 billion difference or so is where all of our COVID costs and our T2 costs are being reflected. So we are assuming about $2.1 billion combined between the two, but that is offset by grants lines in the grants and other or city services lines, depending on it. And the net difference is what we showed in the plan adjustment. So you'll see that COVID, we are down about $350 million this year, and then we do have positives in the later years between $100 and $200 million. So the funds are all offset, but the reason for the major decline in OTPS is COVID.
Thank you.
Good question.
That was the only question. I think this was a just absolutely terrific presentation. First class, really.
Thank you, Sally. Sally, any other questions on the financial plan?
No, that was it.
Okay, I'll go back to Jose. Any questions?
Oh, thank you so much.
No. Dr. Katz? Okay.
Sorry, no
Barbara
further questions, Frida. Thank you.
Thank you. Barbara?
No.
Great.
No question.
Okay, super. And again, thank you to the team. I think this is terrific. I know that we had the good news on the dish map glitch, right? And so that's good. But I do want to point out that this does not include anything that might be coming from the state's budget, fiscal 22 budget and additional risks. And so while that is all very good news, there are still things that are uncertainties, if I'm not mistaken, right?
Yes, there are. Yes.
Yes. Okay. Well, terrific. I think.
Frida,
yes, Mitch.
if I may, I can't see is Deb Brown in the room or not, but I wanted to give her special credit for the work that she did on the glitch. We don't call it lobbying because it's all for government and for good, but the intense effort that she made with legislators, especially with the office of Schumer, that's how you get stuff like this. And it's worth probably over its life $900 million to us. I, of course, told Deb that she should expect the usual share that H&H employees get when they, produce, tremendous amounts of revenue. But I really wanted, to acknowledge.
Hug or handshake, post-COVID hug.
Yes, I just really wanted to acknowledge how much work she and her team did to make that happen, and how many patients will benefit because of that work, because of the number of nurses we'll be able to hire, because of the number of doctors we'll be able to hire, and prescriptions. Right. I mean, $900 million is a lot of care for low-income people, and we are very grateful to her for that work.
Thank you. We echo that, Deb. I don't know if she's in the room, but
No.
No. Okay. Well, thank you, Mitch. Any other old business? Any new business? There being no further business, I adjourn the meeting. Thank you.
Thank you.
Thank you, everyone.
Thank you.
Bye.
Bye.
So John, have we like quantified in any